So today I'm going to talk about incidence of sudden cardiac death in athletes, but as opposed to Aaron, I'm going to talk more about the differential risk. And so a little bit different spin. My disclosures: I'm on a medical advisory board for a primary care company, work for the NBA Players Association, and I also have some volunteer positions and some research grants. None of those should interfere. So about a year ago, the AMSSM came out with a position statement that was led by John Dresner and Fran O'Connor. It was a group of physicians that had strongly opposing viewpoints regarding cardiac screening, and their goal was to try and find some middle ground, or what we could all agree on. And one of the things that was very interesting that came out of this paper was this concept of individual risk, or that risk is not the same for everyone. And so we began sort of thinking this more in terms of equality may not be the same thing as equity. And so do we need to be more precise in our targeting of sudden cardiac death and awareness? And so when we think about sudden cardiac death prevention, it all begins with incidence. And really, what is the incidence of sudden cardiac arrest? And as Aaron mentioned, it's all over the board if you look at it. The incidence will range anywhere from 1 in 50,000 to 1 in a million. And so what's the deal? What gives? The primary reason for the difference in incidences really comes all down to study methodology, primarily. And so I want to talk a little bit and take a deep dive and look at some examples of incidence so that you can understand this better. So there's some limitations to incidence. You need two things to get a reliable incidence: a reliable numerator and an accurate denominator. And so when you're looking at a numerator, problems come in because what cases do you count? Some of the studies will only count cases that occur during school-sponsored sports. Some studies only count exertional sudden cardiac deaths versus non-exertional. Some count death and arrest. And then some count arrest in both athletes and younger people. And so then the question becomes, how do you define an athlete as well? And so there's a number of different variables when you look at a numerator. And just to illustrate this, I want to look at this study that came out of Minnesota from Bill Roberts a couple years ago. And his numerator, he identified deaths by looking at insurance claim data. And so over the course of a decade, he identified one death in Minnesota high school athletes. He figured that all the students were eligible for this death benefit, and so that this should pick up most of them. They had a very accurate denominator, so there's no issues there. And the incidence that they came up with was about 1 in a million. Now, this was a lot different than some of the incidences we'd been seeing in other places. And so we went back and we looked at the media database from Parent Heart Watch, which is a media database. Now, there's a lot of problems with media databases, but it's a little bit different way to look at the same incidents. And what we found was during that same time period, there were 7 sudden cardiac deaths and 7 cardiac arrests in high school students. Now, 2 of those deaths occurred at high school practices or games, so would have been eligible for that death benefit, but only one person applied. So you have to apply for it. It's only $10,000. Some people may not know about it. 3 deaths occurred during sports, but not during school-sponsored sports, so AAU or select sports. And then 2 athletes died in their sleep of cardiac conditions. And so when you look at the difference that makes, there's a 1 in a million figure that the Roberts group came up with. When you look at our data, if you look at 7 deaths during we used an estimated denominator, so the denominator wasn't quite as good. The rate was about 1 in 115,000, which is almost 9 times different. If you looked at just male athletes, because all the deaths occurred in males, it was 1 in 74,000. And if you looked at basketball players, it was 1 in 46,000. So you can see how defining your numerator and your denominator differently really make a difference in your incidence. And if you take that one step further, if you include arrest in that data, it changes it once again. And so if you look at male high school Minnesota basketball players, the rate was 1 in 17,000, which is a far cry from 1 in a million. And so when we're looking at these incidence studies, it's just really important that we pay attention to the methodology. And so the question comes, well, which is right? Well, I mean, it really depends what you're asking. If you're an insurance company and you want to know what your risk is in terms of paying out a claim, well, then that 1 in a million figure is probably the right figure. If you are trying to figure out where to put your AEDs, then another figure might be better. And if you're trying to decide how are we going to mitigate risk by either identifying these things with primary or secondary prevention, another number might be better. And so it comes back to this concept, I think, which Aaron mentioned, which is it's really pretty complicated. And what about denominators? So when you look at denominators, the ideal situation is to have a known population, so you know how many athletes there are. But it doesn't really quite stop there. So you can look at athlete years, but some athletes play and practice a lot more than others. And so you could look at athlete exposures, which is more accurate, or even look at how many hours somebody is practicing. And so figuring out what your denominator is and what you're comparing it to is very important. You also need to know whether the denominator is specific enough. You have to look at the sex, you have to look at the age, you have to look at the race, because if you include females in a high-risk group with males, it's really going to dilute out the risk in the males. And then the other question is the denominator estimated? Many studies will just say, well, you know, there's about this many athletes, and that comes with some inherent problems. And to illustrate that, we're going to look at this study. This was a study that was done in Denmark that looked at sports-related sudden cardiac death. And they had a really good denominator. It was from death certificates, and they have a good surveillance system there. But to estimate the denominator, what they did was they relied on a survey which called up about 4,000 people in 2005. Those people were 16 to 35, and they asked them about their physical activity. And the figure they came up with was about 10.9% of the Danish population would fit in this competitive athlete population. So they basically took 0.2% of the population of Denmark for 1 year. They extrapolated that over a little bit different age range, and then over 6 years. And so there's a lot of places where you can run into some variability in there and get a difference in denominator. The other thing is that the activity was self-reported, and we all know that self-report of activity is not a great way to gauge of activity. And so again, if you look at how that affects the incidence number, the number there was they had 10.9% of people were active, and it came up with an incidence rate of about 1 in 82,000. But if you change that and people were off on their activity reporting, it changes the incidence dramatically. So just another thing to think about. This isn't a bad study, but you need to be aware of the methods when you're evaluating it. And then this is something that Aaron touched on, is that the incidence really changes with age. And so somewhere around 24, maybe 30, maybe 35, there's a shift and the incidence really starts to go up. And that's primarily because of contributions from coronary artery disease, no longer the congenital causes. So if you take this whole group of athletes and define them as 10 to 35, you're going to falsely increase the rate of sudden cardiac death because that higher risk group is pooled in with it. And so again, it's not very granular data and it's not as helpful. So what's a question for us today? The question really is are there high risk groups that we need to worry about? And what's the incidence of sudden cardiac arrest and death? And so we're going to look at our NCAA data because one of the nice things about that data is that it had a real granular, it had a good denominator and it was very granular. So what we found was that there did appear to be some high-risk groups, males and African Americans, and we really weren't the only people that have discovered this. This has been shown time and time again when we look at incidence studies, and these are the incidence studies that actually came up with different incidence rates for males versus females, and they all have different methodologies. They all came up with sort of different incidences, but one of the things that was very consistent through all these studies is that males have an increased risk of sudden cardiac death compared to females, somewhere between 2 and 6 times. And if we look at the contribution of race, there's not as many studies that look at the contribution as race, and they all use a very similar data set, which is the NCAA data set, which really is one of the only ones that calls it out. And so we have 2 papers basically using the same data set, and then Dr. Marin had one which used a very similar data set. And again, came up with similar estimates, which is that African Americans or black athletes have about 3 to 5.5 times the rate of sudden cardiac death compared to white athletes. And when you take this a little bit further and start looking at the risk of sport outside the risk of race or sex, what we find is that there's some sports that have a lot higher risk than others. Basketball, men's soccer, men's football. are all much higher risk than sort of our standard kind of average risk in an NCAA athlete, which is 1 in 53,000. And if you don't get more granular than that, you have a skewed impression of what's going on. If we dive down a little bit deeper in our male basketball data, you can see that African Americans of any division or Division I athletes have the highest rate of sudden cardiac death, which is about 1 in 5,000. And again, looking at other people who have looked at the contribution of sport, particularly basketball, to sudden cardiac death, there's several studies out, and they all see these similar things, that the rate of sudden cardiac death in basketball players is much higher than it is in other sports, and particularly African American basketball players, somewhere around 1 in 4,000 or 1 in 5,000. So there are high-risk groups, at least in the NCAA athletes. Men's basketball accounts for only 4% of the NCAA athletes, but 20% of sudden cardiac deaths. Football and men's basketball taken together account for only 19% of athletes, but 47% of deaths. And football, men's basketball, and men's soccer are 24% of the athletes and 58% of the cardiac deaths. And so if you want to get high yield on your screening, it may be that we need to look at specific groups. This is data from Dr. Siebert, and what he looked at was data from the National Center for Catastrophic Sports Injury Research, and there's no denominator on this, just total cases, and it includes middle school athletes, high school athletes, college athletes, and professional athletes, but he found a similar thing, that men's basketball, or basketball in general and football, was responsible for 54% of the deaths. If you include soccer in that, it's 65%, and if you go down to track, it's 75%, so there's definitely some high-risk sports. So are there high-risk groups? Yes. Men, African Americans, and basketball athletes. And so that, I think, is pretty clear from the emerging data that we see. And then the other thing that we need to think about, which Aaron really touched upon, was that there's a different group of athletes, and that's our older athletes. And they die from cardiac coronary artery disease, and we need to think about them differently and not include them in the same group. So what's the incidence of sudden cardiac arrest and death? Well, I think Aaron came to the same conclusion, which makes me happy, which is it depends. And what we need to do is get away from saying that there's just one number and get more towards this concept, which all of medicine is going to, which is precision medicine and more accurate for the individual. And so as we think about the incidence of sudden cardiac death, we do need to get away from this idea that there's one size that fits all and really think more about individual risk. Thank you.